and I'm glad to have with us today Dr. Jeff Jensen, who is a board-certified periodontist in Utah, and he's the instructor for our Implantology Part 1 program. Part 1, Part 2, placement, and also restorative. He's going to talk today about things that you need to know. It's kind of a preparation for the course, Jeff, that we're going to have. And I'm really excited to be here with you and look forward to hearing these things. Why don't you tell a little bit about yourself?
Sure. Thanks, Dr. Koerner. I'm happy to be here and really excited to be a part of this course and talking about implants and how we can use them in our practice and become more proficient at placing them and restoring them. A little bit about myself. I'm from Utah. I grew up here in Kaysville, just north of Salt Lake City. Went to Michigan for my dental education and finished up in Nebraska for my residency, and just really had a really enjoyable time doing that. Came to love periodontics and treating perio and doing implants and things like that, and love to share that knowledge and help others improve in their surgical skills and their ability to treat patients in different scenarios and to help them have a better oral health.
Well, we're lucky to have you with us. And so what we're going to talk about today is to give them a taste of what the course will be like. Of course, the ultimate thing is that they would be able to actually place implants on patients after these 2 sessions. We also have oral surgery courses that we expect them to be a part of so that they're better at things like incisions and flaps and, bone removal and that, so that's not foreign to them. So that'll be part of it as well. But why don't we get started talking about some of these patients. We're going to talk about case selection, we're going to talk about diagnosis, we're going to talk about treatment planning, and then the actual procedure, kind of like we would in the course, kind of like they would do with their own cases.
Sure.
So why don't you go ahead and get started?
Sure. Well, this first case that we'll talk about is a patient that I saw in my residency, and we'll kind of go through this together. But the patient presented to our clinic. It was a 22-year-old male patient, and his chief complaint was that he was missing 2 teeth on his bottom jaw. And so as we spoke with him and kind of went through our exam, we learned that both tooth number 20 and 29, so lower premolars, were congenitally missing. So he was born without these teeth, and he had been in orthodontic treatment for a little while to create some space and to open that space up so eventually we could replace those teeth.
Jeff, if I may say just one thing, as they're listening to this, I want them to get involved in this case as they would get involved in a case similar to it in their own office. The things you're going to talk about, the things you're going to present, are the things they need to think about as they're getting ready to do a case. They can't just go in and start doing it. They have to plan for it as you're doing. All these things, even what you mentioned briefly already, are part of getting started in the process of being able to do a successful implant, one that will last a long time. We're talking more about the beginning part of it. Dr. Davis will talk more about some of the restorative aspects, but it's all a process and it's all a package, isn't it?
Yep, and it's a comprehensive exam. It's not just we want to do an implant, but what needs to happen before the implant, or what does this patient need that they've missed out on in the past. And then I start to think about, you formulate a pattern and you start to see things differently and think differently as you see these cases. And so with this case here, when I hear a patient tell me they were born without a tooth, the first thing that I think of is, what's the bone like? Because we all know, we've seen patients that maybe are missing a lateral incisor. They were born without that, and when they come in, we see that real big dip on that buccal plate of the jaw, and we know that there's going to be a problem there if we try to do an implant because they were born without a tooth and there's not enough bone there. So when I see this patient come in and say, I'm missing these 2 teeth, born without them, my first thought is, how much bone is there? and what does the space look like? You know, he had ortho, but has he been wearing his retainer? Has he been following up on that and keeping that space open? You know, these are all things that are going to come into play.
Well, so this may not be an ideal case in that regard, but if we teach them how to put bone back there, then it can become ideal.
Yep. You'll learn some tricks and some procedures that you can do to help these patients get the treatment they need and want.
And because we're limiting what we're teaching to single site and mostly in the posterior, it's kind of like entry level, but they're going to become very, very good at that level of implant. And then later they can expand and go on to bigger cases if they like.
Sure. When we learn the basics, then we can build on that. And becoming a master of the basic techniques in surgery and implant dentistry allows you to increase your skill set and become more proficient at that procedure and those sorts of cases. So let's take a peek here. So just a couple things on his medical history that he noted. Patient was diagnosed with high blood pressure, so he's taking a lisinopril daily. When he came into our clinic, his blood pressure was fairly good, a little high, but he was probably a little nervous to see us. Other than that, really no other medications that would be a worry to us. He does report an allergy to cephalosporins, but we're not going to give him any of those. So that's nothing too worrisome on his medical history. So these are things, again, I'm going to work through a system. I'm going to have a pattern of how I treat these patients. How do I do my exam? How do I determine what needs to happen? So no red flags here on his medical history. So if we look here at his presentation dentally, okay, we have some photos here of our patient, and then you can see I took some measurements with my probe. So again, this is something you can do in your office. You can pick up that periodontal probe and make some general measurements. So the three that I typically look at first are, what is my mesial distal measurement? So from the contact points on the adjacent teeth, or from the cervical areas of the teeth, what's my width? There. Buccal lingual, so if I measure from buccal to lingual, how thick is my jawbone horizontally? And then intraocclusal, so I have the patient bite together and I put my probe in and see how much height we have. Is there enough room to place a crown? So when we look at this patient, if you look at these occlusal shots, he's actually got quite a bit of bone from buccal to lingual. So that first thought I had about what's our width is put to rest a little bit. Mm-hmm. But one thing that we see on this case that could come into play, especially restoratively, is on number 20, that mesial distal measurement is a little small. So I measured about 5.5, and if you look at that photo with the buccal shot on number 20, you can tell that that's a little bit smaller than 29. So he's had some sort of movement, or the teeth have closed just a little bit. So that's something that we're going to discuss with him and his restoring doctor, the doctor who's going to be making the crown.
Yes, and really what we're teaching in this course is that whoever's listening would do both.
Yep.
In your case, you wouldn't do the restorative, but they will be, because we're covering both parts of that. So you said 5.5 millimeters mesiodistally. Where would you say you couldn't place an implant?
That's getting a little close. I have to be able to actually place the implant. So if I'm using a 4 millimeter implant, then when I go between those two teeth, I'm only going to have 1.5 millimeters clearance. So that becomes a little bit tight. And again, I'm using a probe here, so it's not. I can be a little more accurate with radiographs and that sort of thing, but I would say around 5 to 6 is where your minimum, especially for a premolar. Okay, sometimes if we're doing something in the anterior with a lateral incisor, it's a little smaller, but a premolar, I would say around 6 is where you'd like to be at the smallest.
Okay. What about as far as implants go? Would you consider, like, instead of a 4, if your company had a 3.5?
Yep, I would be comfortable doing that in a premolar, so that would be an option here as well for the patient.
And when you get up to molars, then it's something like in the area of a 4.3 would be your minimum.
Yep. Yep, a
Width.
regular. Yeah, we would call that more of a regular platform rather than narrow. So
Yeah.
this would be a good candidate for a smaller implant if we needed to do that. One option that we can discuss with the patient regarding this is some enamel reduction or some enamelplasty on the molar and that first premolar. If we can relieve a little bit and give ourselves another millimeter or so, I think we'd be in a good place. If we look at the radiographs here, so we'll go through this together real quick. This is always a part of my exam, obviously, is radiography. I'll typically start with a pano or PA and a bite wing to get a good idea of what's going on in the bone or with the roots of the teeth or the places that we can't see with our naked eye. So if we look at this number 20, this is the site we were just talking about, was a little narrow. If we look at that root on number 21, that root is to the mesial. So when we actually look at the space for the implant, we've got plenty. The cervical area, the cervical spot, the cervical width is very wide. It's much more than 5. So we're not worried as far as root proximity. We've got plenty of room. Okay, so our challenge here is more of the restorative aspect. We see the mental foramen most likely apical to number 21, so we've got plenty of clearance there. We're not near the inferior alveolar nerve, so this would be a good case to place an implant, and you'd be pretty clear doing that, in my opinion. Again, on site number 29, this we see a little bit more space, interproximal between 29 and 30, or I'm sorry, 28 and 30. And again, our height, we've got plenty of space before we run into the inferior alveolar nerve.
So how much above the bone level, how much space would be, enough? And less would not be good. Are you talking about like 5 millimeters, 6 millimeters of space between, let's say the soft tissue and the opposing occlusion, or the bone and the opposing occlusion? Where do you measure that from?
So my interocclusal space.
Right.
Yep. So I typically, when I'm using a probe, I'm measuring from the soft tissue, typically the gingiva, to the opposing arch where that tooth is. If I'm 6 millimeters or above, I feel comfortable that we can at least get a screw retained crown on. That you can usually make those a little shorter if you need to, but if I have that 6 millimeters, I'm comfortable with restorative on that.
That sounds good. So you've got enough.
Yep. I think we're good to go. So when we discussed, obviously, with this patient, his options are no treatment, so we can leave a space, but that's why he came in, to fix that. Right. We have fixed partial dentures, but again, with the patient this young and virgin teeth, that's probably not the way he wants to go, or we would. And so implants at number 20 and 29 would be my recommendation, and that's eventually what we ended up doing.
Sounds good. Now, will we talk about 20 later, or not? Is that one of our cases that we will, like number 20? We're working on 29 now, right? So you say there's 2 implants that will be done?
Yep. Okay. So we'll place, we plan to place implants at number 20 and at number 29.
Okay. Okay, so on the opposite side of the arch.
Right.
Why don't we edit that a little bit? Let's just start back and let me ask that question again. Can we?
Go ahead.
Okay.
So do you want me to be here?
Yeah. So you're going to be placing 2 implants, 20 and 29, and so are those sites pretty equal, or do they have a big difference in them? And will that be one of the other tooth be one of the cases that we will discuss in this program?
Okay, so what are you asking me?
So they're going to place. You're going to place 2.
Oh yes, it'll be.
Is the other one that we're not talking about now going to be a case discussion?
Some of the other cases.
Yeah. Or no?
No, I don't think I have a first premolar on the bottom. I have some first molars, but...
So we're not talking about 2 implants on this one patient, just the 1 implant on this one patient.
So this patient's going to get 2 implants, but...
Is our discussion going to be of both those implants or just one of them?
So when?
So this discussion right now is geared to one of those, 29, right?
Yeah, so we talked about 29, we talked about 20 already with the spacing.
So we are doing both of them. This discussion is both implants.
Yeah, this is everything. This is one patient.
Okay. So what we ought to do is, let's go back there to that point. The question I brought up here, let's just not even talk about it, because I was trying to, I didn't know if we were going to cover both of them in detail, and you are. You're going to cover both of them.
So that's what I have on that.
Okay.
So we were.
I just wasn't sure that you were going to discuss both of them equally or just one.
So 20, to me, we spent a little. I think we spent a little more time on number 20 because that's the one that was
narrow,
not enough space.
Right.
Versus, I mean, 29 is a pretty straightforward.
Okay, so then let me say something. So can you put a timeline on that?
Well, just what do you mean a timeline?
Like to bring up this as an edit point?
Yeah. What I'm going to do is I'm just going to make a note of where we want to start up again.
And then I can listen to it and give you exact numbers.
Yeah.
Okay, so let me start over again.
Where do you want me to be?
Just right there. No, the back one. Okay.
Or here.
There.
Yeah.
So, Jeff, what we're doing is with this patient, I mean, you've talked about one, now we're talking about another. So you're using this as a teaching experience, a learning experience, to talk about these 2 different sites, 2 different implants, 2 different sets of problems, and how you would deal with them separately to get the best outcome in each situation.
Sure.
Okay.
Yep, we're each case, even in the same patient. I mean, this is the same patient, just mirroring teeth. Each area has a different challenge, right? So, number 20 was narrow in the interproximal space. How are we going to fix that? How are we going to treat that? Number 29 was a little bit more straightforward. You know, we had straight roots, we had plenty of distance between the 2 teeth, so it's a little bit easier to do. But again, each case is different, and each case needs to be looked at individually.
And you know, as we do this with these 2 teeth, 1 patient, 2 teeth, and then others, every case, as we discuss it, they can pick up certain points that will apply to situations that they have, that that they need to work through.
Yep.
And make decisions.
Yep, and I think the key to some of this is to have a pattern. To develop a pattern of how we do an examination for an implant. What are we looking for? What are some of the key points that we want to cover with the patient and the case, so that we can be thorough and make good decisions.
Okay, sounds good. Well, keep going.